have a lot of suggestions regarding fellowship here, but I do think that when they bring on someone as old and beat up as me, a little complimentary Botox might be in order. In my case, it might take a little more than Botox, but at any rate. So no financial disclosures. Again, in retrospect, I should have added or disclosed that I've loved my time here at Doheny. Dr. Sada, Dr. Ib, Dr. Sadoun, and many others have made this an extraordinary experience, and I am forever in their debt for that kindness. So, patient, 20-year-old woman. At around the age of 5, she had some vision loss, and examination suggested an inherited retinal dystrophy, most likely autosomal recessive. She had an ERG, which was not extinguished at that time, as might be seen in something like Leber's congenital amaurosis. Her ERG did suggest a rod cone degeneration, as we would often see with retinitis pigmentosa and a few other conditions as well. So at that time, phenotypically, her exam most closely resembled that of a condition called severe early childhood onset retinal dystrophy, or CCORD. CCORD is, as with Leber's, is caused by a variety of different genes. There's some overlap both genetically and phenotypically, but RPE65 can account for both of these conditions. The importance of which I'm sure you all realize is that there is now an FDA-approved gene therapy treatment for disorders associated with RPE65. However, our patient didn't have either of those. So when we saw her, again, about age 20, she said that her peripheral vision is continuing to decline. Her vision was certainly not adequate for driving. Night vision, even worse than daytime vision. She was otherwise healthy with the exception of the somewhat unusual condition of hypogonadotropic hypogonadism, for which she was receiving hormone replacement therapy. Pertinent to our history, however, in exam was that she didn't have any ataxia, she was of normal stature, and she was a college student doing very well, a very intelligent young lady. So very poor vision, otherwise a normal exam in terms of the anterior segment. The posterior segment, what we typically see with retinal degenerations, vascular attenuation, a little bit of disc pallor, and some very diffuse and rather severe chorioretinal atrophy. There is some functioning or intact retina here in this right eye, which probably accounts for her slightly better acuity in the right eye than in the left, which is largely devoid of such islands of residual functioning retina. But for those of you who have seen many cases of retinitis pigmentosa, you'll probably agree that this is a rather severe phenotype for that classification of disease. And her static fields represent what we would expect to see based on her fundus photos. A lot of central depression with some islands of relatively preserved sensitivity. So she underwent a standard RP panel a few years earlier, which did not produce a result. And one of the clinicians wisely then sent her for a whole exome sequencing. And it was found that she had mutations, compound heterozygous for PNPLA6. And this put her in the category of a disease called Boucher Neuhauser Syndrome. Just a quick word on genetic testing. There's a lot of different options out there, and for those who aren't doing this on a daily basis, it can be a little bit confusing. I've tried to simplify it in my own mind. A targeted panel, a targeted panel which might include just one gene or a set of genes within a certain disease category is a bit like reading selected chapters, a single chapter or a set of chapters out of a book. The whole exome sequencing is like reading every chapter that's in the book, and the whole genome sequence process is like reading every individual letter that's in the book. So all of the chapters, plus all of the footnotes, all the copyright information, dedications, prefaces, and so forth. The popular consumer gene testing that we see advertised quite frequently doesn't really fall into any of these categories. It's rather more of a genotyping rather than a sequencing process. And it might be thought of as reading a brief synopsis to selected chapters of a book. So this syndrome came to be recognized relatively recently in medical standards. Boucher and Gibber described a couple of the features back in '69. Then Neuhauser and Optis added some additional characteristics that they observed. Now, again, at this point, the gene defect was not known. So we've come to now consider Boucher Neuhauser as consisting of a generally severe chorioretinal dystrophy, ataxia, which our patient did not have at the time of presentation, but which has been noted to occur later in the course of the disease, and hypogonadotropic hypogonadism, which she had been treated for several years. Just a word on the hypogonadotropic hypogonadism. In this condition, the gonads, the testes and the ovaries, are functioning normally, but they're not receiving gonadotropin signals from the pituitary gland. So they don't produce the hormones that they should be producing. So as I mentioned, Boucher Neuhauser represents a defect in this patatin-like phospholipase domain 6 gene. It's also sometimes called neuropathy target esterase. Its function is to convert, Its function is to convert this molecule into this molecule, both of which are needed for neuronal development and are precursors for acetylcholine. Interestingly, and the reason why this protein goes by another name, it's sometimes called neuropathy target esterase, is that this is the protein that's affected by pesticide, organophosphate, and even chemical weapons, which often are organophosphate-based as well. So patients that have this condition, it's almost as though they have a very, very slow subacute sort of a chemical weapon poisoning type of syndrome. So again, the protein converts this molecule to this molecule, which is essential for proper neuronal development. Now, as with many genetic defects, there can be some different phenotypic manifestations. I've kind of arranged these in least severe to most severe. These are all due to the defects in the same gene, but produce increasingly severe and varied manifestations. So on to a little more detail. In our patient, we noted that on OCT, she had a structure here that we've come to recognize as an outer retinal tubulation. She also has some features which previously have sometimes been confused with outer retinal tubulations, and that is a little bit of fluid cystic spaces here. The relevance of being able to distinguish these two is that this sort of a condition, fluid within the retina, is amenable to treatment, whereas this structural feature will not change in the setting of anti-inflammatory or carbonic anhydrase type treatments. And here's just a little better picture of this structure. Again, you can see a dark interior, not unlike that of edema, and then a hyper-reflective outer zone, which distinguishes it from edema generally. So outer retinal tubulations are a relatively new finding as well. We've only known about them for about 10 years, and this probably is because around 2009, optical coherence tomography was getting good enough to be able to make out such very small structures. It's subsequently been identified with a lot of different conditions. This is an incomplete list. There's many others as well. It had not previously been described in Boucher Neuhauser Syndrome, so we were the first to make that finding. Dr. Zweifel and some others have presented an interesting and perhaps one of the better explanations for how these tubules form. The pathophysiology, I believe, tends to begin in the RPE or the choroid rather than being a pure photoreceptor oriented disease process, but then breaks in the external limiting membrane and various tractional forces within the retina cause the what we now call the ellipsoid zone to form a circling of the wagons kind of a structure, and this represents these ellipsoid zone bodies or structures are what we see as the hyperreflective finding on the OCT. So as a bonus, we thought we would also look at OCT angiography in this condition. OCTA, of course, is a even more new imaging modality than OCT itself, and OCTA had also not been described in Boucher Neuhauser, so I'm always looking for an easy poster or presentation, and so we decided to do OCTA in our patient. This is a raw image of showing the large choroidal vessels, but no choriocapillaris, or other eye. And just for comparative purposes, this is our 20-year-old female Boucher Neuhauser patient showing a complete lack of choriocapillaris that we would see in a normal patient. This is a 20-year-old choroideremia patient, a 40-year-old choroideremia patient. So in my mind, this is a condition which, if the person were male and thus subject to an excellent condition, might potentially be confused with choroideremia, although as you can see, the progression is much earlier and much faster than in choroideremia. So, to kind of round things out, Boucher Neuhauser, as with many other degenerative retinal conditions, does have outer retinal tubulations that you can see on OCT. Again, the importance being that we should distinguish those from true retinal edema, since they are not amenable to treatment, nor would they need to be treated. And as an adjunctive imaging modality, OCTA will show a profound loss of choriocapillaris, not unlike that of choroideremia, but more severe and earlier. Now, I'd like to see a show of hands of anyone who has seen a case of Boucher Neuhauser syndrome. No, I see no hands. So I don't think it's critical for anyone in the audience to really remember a lot about Boucher Neuhauser syndrome, although I do think it's interesting. I think the important thing, the thing that I've learned from this case and from many other cases that I've had the pleasure of learning about from Dr. Sada and Dr. Ip and others, is that whenever we see something that appears to be a retinal degeneration, we should first rule out treatable and reversible causes. That might mean infection, it might mean a toxic retinopathy. When we've ruled those out and we're still left with what appears to be a retinal degeneration, rather than concluding that it's an isolated disease process, we should very closely examine the possibility that it might be part of a syndrome. Even in patients that are walking, talking, conversing, and who look quite normal. The reason being, of course, that some of these syndromes have very important implications to the patient's future health and well-being. And this is a case that I saw up at KCI Institute, and very much appreciate the collaboration of those folks. And that's all I have.
Thank you, Dr. Will. We have time for one question or comment. Yes, Dr. Sada.
So yeah, I'll make a comment. Terry, thanks for that nice presentation of a very rare condition. I've never seen that condition, although I'm sure Bill Freeman's got dozens of them in his clinic. But But in any event, I think you highlighted the important features, including in particular the severe choriocapillaris injury or loss that's present in that patient. And Mike and I were just commenting as you were presenting the case that it did look, before you talked about the relationship or the similarity to choroideremia, we thought, well, it looks like inverted choroideremia or choroideremia inversus with the center more involved, and maybe that could be helpful for people in suspecting this kind of a problem. But I am glad that you brought up OCTA angiography, in particular the choriocapillaris imaging, because people mostly think about OCTA angiography, you're looking at the retinal circulation, but I certainly believe that the most important achievement of OCTA angiography is going to be our ability to visualize the choriocapillaris, and we're finding that it's uncovered, given us so many insights into so many different diseases that we are now evaluating by looking at the choriocapillaris, whether it be placoid, inflammatory diseases where the choriocapillaris findings, as you know, can be diagnostic, but also in these inherited degenerations. And I think that, again, we found it to be very informative in the retina space, but I'm looking forward to seeing, for example, that we have the glaucoma table there. I think that they'll be interested going forward looking at the choriocapillaris, that condition as well. So I think that you beautifully illustrated in your talk how we're able to do that with OCTA angiography.
Thank you, Dr. Sada, and thank you, Dr. Wood.
Peter, can I just make one other comment? Because I wanted
Sure.
to put something that he presented in
As
a greater...
As long as you're brief.
In a greater clinical context. So the outer retinal tubulations that you went over, I mean, you have to think of it as it's sort of a common end-stage pathway from a lot of different pathologies. So at the reading center, we're looking at a lot of choroideremia images. We see it in choroideremia, but also I think you should note, and I think you pointed it out, we see it in geographic atrophy from AMD, but also in exudative age-related macular degeneration. I think the CAT study looked at this, and it was like 20 to 30% of the eyes have this. So from a clinical perspective, it's important to recognize this in wet AMD as an endpoint where the eye is degenerated beyond what you can keep treating with anti-VEGF therapy. So I think it's very important to distinguish ORTs from cysts, from fluid, from exudation. That's all I wanted to comment on, Peter.
Great, thank you.
Thank you.
Thank you.